So it started live, sir.
Let's not go live yet because.
Yes, sir. I mean, I'm saying like I'm gonna share a screen. I mean, this will be projected.
Okay.
Yes, sir. I mean, I'm saying. I mean, this will be projected. So your YouTube audio is on?
Yeah.
Fine. So I thought I know my YouTube audio is on. That's
Can you
why
hear
I'm
me,
muting
guys?
it again.
Yep. I have a quick question. Yeah,
Hello?
Jack, we can hear you. Srividya.
Yes,
now,
sir.
The question that I have is, with the slide that you've put on, can they also hear us on YouTube live right now?
Yes, sir.
We should probably mute it, right? And wait until 7:30 to...
Yes, sir. We can mute ourselves. I'll mute it, sir.
Just on YouTube live. We can talk, but just on YouTube live, if we can...
Oh, that can't be done, sir, because this is what is happening in Zoom will be streamed there. Like whatever we talk.
But in that case, can we go live on YouTube at 5 p.m.?
Okay, wait. Okay, sir.
What is the disturbance? Is it because of the YouTube or?
Okay, so before we start, I'll share the screen. Okay, so before we start, I'll share the screen.
sorry, there was some connectivity issues.
That's fine.
Yeah, back on track.
All right, I think we can go live.
I think we can start, sir.
Okay. I think right now they can only see the screen, right?
I mean, no, sir, they'll be able to see you and the screen.
Okay, wonderful. All right. Good morning, everybody. My name is Dr. Haresh Sampath Kumar. I'm the co-founder of JH Rehabilitation. I welcome you all to the webinar series that is going to be focusing on post ICU rehabilitation. So this is going to be a webinar series that is going to span over a period of 4 days with speakers from various specialties that are going to discuss about post ICU rehab. The topic for today is overview of ICU management of COVID-19 patients and their outcomes as it relates to deconditioning. So the presenter is an ICU attending, Dr. Navita Ramesh. She's a board certified physician in pulmonary and critical care medicine and holds a testimer status in advanced critical care echo. She's also the president-elect for Pennsylvania chapter of critical care medicine. Currently, she's practicing in UPMC affiliated community hospital. She's also a big proponent of early mobility in ICU patients. So we couldn't find a better speaker for this topic than Dr. Navita Ramesh. So without taking too much of her time, I would like to ask Dr. Navita Ramesh to take over.
Hi, good morning, everyone. So my name is Navita Ramesh. I'm a pulmonary critical care physician working in Pennsylvania. And today I will be talking about COVID-19. And as you know, it's a huge topic, and you need several days to talk about the topic and cover it in full detail. So my focus today will be on COVID-19 from the critical care aspect with focus on rehabilitation. So how can the critical care community as well as the rehab community work together to improve the quality of life of these patients? So as you all know, COVID-19 is an infectious disease. It was discovered very recently. It is found to be caused by a virus known as SARS-CoV-2 or coronavirus. It initially originated, or the first cases were discovered in Wuhan, China on December 2019, and hence it gets the name COVID-19. So brief background and time frame. In December 2019, in Wuhan city in China, this became the center of an outbreak of pneumonia of unknown cause. As of January 7, the Chinese scientists had isolated the new virus. And in February, the very next month, it was designated as COVID-19 or coronavirus disease 2019 by the World Health Organization. In March, the World Health Organization labeled COVID-19 as a pandemic. At that point, it had affected 114 countries all over the world. And the initial thought was there was zoonotic transmission event associated with large seafood market. But as you already know, there is evidence of person-to-person transmission at this point. So this is a study, this slide is from a study that was published from a hospital in China, one of the earliest affected hospitals. And I chose this slide just to give you an idea about the clinical course of the disease. So this study looked at people with COVID-19 confirmed and who were survived the hospital course and the ones that had not survived. So as you could see, the fever and cough are the most common presenting symptoms. They present since day 1 in this population cohort. By day 9, they develop sepsis, day 9 or 10 in non-survivors. And by day 10, they develop ARDS. So it's adult respiratory distress syndrome, that's severe hypoxemic respiratory failure by day 10. The focus of this slide for me is to look at the day of discharge. So the patients on an average were discharged on hospital day 22. So this is people with sepsis and ARDS who had been in the ICU discharged on hospital day 22. This slide is from Johns Hopkins University of Medicine, the Coronavirus Resource Center. This is of two days ago, where it just gives you an idea about the total confirmed cases in the world. It's 3.5 million. And it gives you an estimate of the total deaths and what kind of trajectory are we following with this disease worldwide. So brief snapshot again from the COVID, from the Johns Hopkins page. If you see down below here with 42,000 cases is India. So India is number 15 in the world based on Johns Hopkins University data we have so far. So just to give you an overview of this disease. So we know that this is caused by a virus that was newly discovered, and the epidemiological risk factors, or who is affected more by this virus. So age 55 to 60, and those with comorbidities, which include diabetes, hypertension, chronic kidney disease, heart disease, COPD, and immunocompromised patients like transplant recipients and HIV patients, and also those with morbid obesity. As with any respiratory disease or any pneumonia, the patient is in respiratory distress. So respiratory rate more than 24, heart rate more than 125, and oxygen saturation, they're usually hypoxemic. As more data evolves, some laboratory markers have become more important, which include D-dimer elevation, ferritin elevation, lactate dehydrogenase elevation. Also, the key factor that has come out in this is the lymphocyte count is usually low. That's the absolute lymphocyte count less than 0.8. And given the inflammatory state of the disease, the C-reactive protein is usually higher. So the spectrum of the disease, a majority of the patients, almost 80% of the patients have mild disease. It's almost like sniffles. They have mild disease, but they do not require hospitalization. Among the hospitalized patients, about 10% or 20% admitted to the ICU. Of them, about 10% require intubations and about 2 to 5% die. This is it's a very fluid state. As more cases are discovered, more literature comes out, these numbers are bound to change. But this is as of February. Again, the key factor here in this slide is the long-term outcomes of these patients. They depend on ventilators for a really long time. So that's prolonged ventilator dependency. So the patients who survive the initial phases, they still require a lot of ventilator support. So with the ventilator support come other issues like sedation and paralysis, which I'll be talking about in a little bit. So from the ICU perspective, how does this COVID-19 disease affect our ICU population? As I mentioned earlier, it causes ARDS, which is characterized by diffuse alveolar damage or severe hypoxic respiratory failure. And there's another entity that comes along with this virus, viral infection called cytokine storm, which is characteristic of this disease where there's significant inflammation. It's an overall severe inflammatory state in the body, and that's why the C-reactive protein and ferritin are elevated. And once the cytokine storm is present, it indicates very severe disease and high mortality rate. So now we've spoken about what the virus is, who's more prone to getting it. And so now we will come to what are the common signs and symptoms. So usually it's high fever, fatigue, and dry cough. However, I pulled this slide from PulmCrit, which is a blog which publishes literature as it happens. So as you see here, the presenting symptoms of various papers published in NEJM, Lancet, and BMJ. The symptoms that are most common in most of these papers is cough, 68%, 71%, 77%. So patients present with cough. The next one is fever. Some studies have reported 43% fever. Some have fevers as high as 98% of the patients had fever. And the third most important thing will be dyspnea or shortness of breath. So as I mentioned earlier, very briefly about, so the patients need prolonged mechanical ventilation once they hit the ICU. And what are the unique challenges faced in these COVID patients? First one is analgesic sedation. So these patients remain on the vent for over 7 to 14 days, which is the usual average. And these patients have dependence on the sedative medications that we have been giving them in the ICU. And once we start weaning the sedation, they could go into withdrawal as well. There's increasing literature and increasing support for neuromuscular blockade or paralytic medications to help with oxygenation and also to help with patient ventilator synchrony in this population. And prone position has been used for severe ARDS for several years now, but it's gaining resurgence with this COVID pandemic. And patients with a severe hypoxic respiratory failure, there is some literature to say that they have improvement and survival benefit with use of ECMO. So my focus is to talk about the neurological complications and how it affects the mobility or the functional status of the patients once they have COVID-19. So the common complications or the neurological complications with COVID-19 are delirium, especially in the ICU population. There is ICU-acquired delirium as well. The next important topic is critical illness myopathy or neuropathy, especially in patients who have extended paralysis, and cerebrovascular disease or stroke. And the remaining down here in the bottom, they're just case reports that have been published, but no case series or randomized trials of Guillain-Barré syndrome, ADM, acute necrotizing encephalopathy, or viral encephalitis. Again, this is another paper that came out of China, talking about the neurological manifestations. They looked at neurological manifestations of COVID-19 patients between January and February of 2020. And they divided the neuro complications into 3: CNS symptoms or central nervous system symptoms, peripheral nervous system symptoms, and muscular symptoms. So of the 214 patients who were admitted with neurological symptoms, admitted with COVID-19 to this hospital, 1/3 of them had neurological symptoms. either central nervous system, peripheral nervous system, or skeletal muscular injury. So it is pretty common with this disease. So now I picked out 2 studies that talk about strokes. So why does COVID-19 cause strokes? So there is more and more evidence now to say that COVID-19 causes a hypercoagulable state in patients that are affected. And the first study has 220 patients. That was also a study out of China that detected acute ischemic stroke in about 11 patients, cerebral venous thrombosis in 1 patient, and also intracranial hemorrhage in a patient. So it's important to note that the patients who had cerebrovascular complications, of these 13 patients, 12 of them had very high D-dimer, indicating that the patient is hypercoagulable with the infection. The second one is a case series of only 5 patients, but the reason I picked this is it's important to note that in this case series, it's young patients who are less than 50 years of age who had a large vessel stroke. So usually in younger patients with ischemic stroke, the hypercoagulable workup would need to be done. And for these patients, it was thought that COVID itself caused the hypercoagulable state, and hence younger patients developed large strokes. So why does COVID cause this neurological injury? Why does it cause the stroke, the central nervous system, peripheral nervous system, and muscular injury? So this is mainly extrapolated from the literature that we know from the SARS and the MERS virus, which had happened several years ago. It's thought to be due to hematogenous or retrograde neuronal spread of the virus directly into the neurons. The skeletal muscle injury is thought to be related to the ACE2 receptors in the skeletal muscles. As we know, this COVID-19, it attaches to the ACE receptor in the lungs, and similar, it is just the hypothesis that it affects the ACE2 receptors in the skeletal muscles as well. And this causes a pro-inflammatory cytokine storm. I borrowed this slide from one of other studies published in China. The reason for this slide is right at the bottom. It talks about creatine kinase. So this table specifically looks at laboratory findings of COVID-19 patients with muscle injury. So they divided these patients into severe COVID-19 and non-severe COVID-19. And within each of these groups is divided into those with muscle injury and those without muscle injury. And if you see the creatine kinase at the bottom, it's the p-value is significant. So those with COVID-19, whether they have severe disease or non-severe disease, they do have increased muscle injury. So I borrowed this from the Australian New Zealand Intensive Care Society guidelines, just to say that not only in China, even the other parts of the world, they are recommending that's the neuromuscular blockade prone positioning for COVID-19 patients, and both of which increase the risk of muscle injury and critical illness myopathy, as we'll talk in a little bit. And the only kind of saving grace here is corticosteroids are not recommended for ARDS with COVID-19. But they can be used if the patient with COVID infection has another indication for steroids, like if they are in refractory septic shock or if they have a COPD exacerbation, then steroids are used. Otherwise, steroids are not standard of care for this patient population. Now coming to management, as I mentioned in the beginning of this topic, you need a whole day to talk about the management of this disease if you had to go into every specific study and anecdotal literature that we have. But as of right now, prevention is the most important thing. So hand washing, social distancing, trying not to touch your face and your eyes, nose, any of the mucous membranes, cover your mouth when you cough, and seek medical attention if there is difficulty breathing or you develop fever, and follow the recommendations given by the healthcare authorities. I'm going to just spend a couple minutes on the actual medical management of this, but it's going to be very brief. So the antimicrobials that have potential activity against SARS-CoV-2. This is case reports that have come out, some studies that have been done. They looked at chloroquine, hydroxychloroquine, initially looked promising, but there are significant adverse effects. Initial studies from China had looked into lopinavir and ritonavir. Initially, there was some benefit, but later the more recent trial said this is not beneficial on COVID-19, so we're not using that. Remdesivir is the latest one that got emergency FDA approval as of last week, that it's useful in severe COVID-19 patients who require hospitalization. And ongoing clinical studies with another medication called favipiravir is going on as well. This slide looks a little bit crowded, but again, this is adjunctive supportive therapy, which is not proven at this point. They've tried azithromycin immunomodulating agents, convalescent plasma, that's investigational. It's no strong evidence. Steroids, as I mentioned before, it's not beneficial and not indicated. Inhaled pulmonary vasodilators, which have been used in severe ARDS, they're used only like as a Band-Aid, as a temporizing measure. Anticoagulation is recommended in these patients, given the hypercoagulable state inherent to the virus itself. The recommendation is to use a low molecular weight heparin if possible. Fibrinolytic agents, if needed. NSAIDs, the FDA here continues to say, NSAIDs continues to recommend not using it, but there's no strong data for that. And bronchodilators, if you're giving NEBS, nebulizer management, it increases the aerosolization, and hence MDI or metered dose inhalers are preferred. Very briefly about ECMO, or extracorporeal membrane oxygenation, which is used as like a heart-lung device if patients are in severe respiratory failure or in cardiogenic shock. VV ECMO, which is the venous ECMO, it's used in ARDS and refractory hypoxemia. And VA ECMO if the patient has cardiogenic shock and fulminant cardiomyopathy, which are a part of the cytokine storm that occurs with COVID-19. So there is evidence or case series that ECMO has been used successfully in COVID-19 patient population. So the American Physiatry Association has resources for physiatrists or rehab physicians. This is on their website. If you just Google American Physiatry Association, it has various resources of how to take care of these patients of COVID-19, how rehab will help them, and also how to take care of the practitioners' mental health and well-being as well. So this study is interesting. It came out of Journal of Rehab Medicine, which focuses on the exact topic that we're talking about today, COVID-19 and post-intensive care syndrome. So post-intensive care, as the name suggests, it's post your ICU length of stay. So what happens to these patients once they've survived the ICU length of stay? So what are the symptoms? What do they develop? And how can we treat them? So it has been proven that the longer that the patient stays in the ICU, the higher risk of long-term physical, cognitive, and emotional complications. And the post-intensive care syndrome itself comprises of cognitive impairment like memory issues, psychomotor issues, impulsivity in these patients. Some of them develop psychiatric illnesses like anxiety, depression, or post-traumatic stress disorder, physical impairments like pain, dyspnea. The last part is interesting because part of the post-ICU syndrome itself has muscle weakness, fatigue, neuropathies, and decreased exercise tolerance. So what are the risk factors for PICS or post-intensive care syndrome? So the risk factors are delirium. And as I had mentioned, these patients with COVID-19 with prolonged ICU length of stay are at increased risk of delirium. The duration of ICU admission, the longer the duration, the more risk of having post-intensive care syndrome. Duration of sedation, so the longer they're intubated, sedated, paralyzed, that increases the risk of PICS. Duration of mechanical ventilation, age, hypoxia, sepsis, glucose dysregulation, that's hypoglycemia or hyperglycemia, and pre-existing mental and physical comorbidities. So they increase the risk of developing post-ICU syndrome in these patients. So now coming to the societal impact. So why are we so concerned about post-ICU syndrome from a society perspective? So other than the patient himself, the patient themselves are not going back to their baseline to begin with, but how is it affecting everybody else? Okay, so nearly 1/3 of these patients who experience post-ICU syndrome do not go back to work. Another 1/3 do not go back to their pre-ICU work or a job that had a pre-ICU salary, which is a big deal for these patients. And about 25% of these patients have loss of their independence. They require significant assistance in activities for daily living, even 1 year after ICU admission. So that's an enormous burden on the caregivers. So critical illness polyneuropathy patients, they suffer from decreased exercise capacity and compromised quality of life months or even years after their ICU stay. So it's not just the patient had COVID-19, they lived in the ICU, they got better, now they're back to their baseline. No, the critical illness aspect lingers with them for years to come. So I'm just going to read out this consensus statement from Post-Intensive Care Syndrome with an overview. The paper was published in 2017. It says early rehabilitation, that's important, early rehabilitation, combining mobilization with physiotherapy. It's an important strategy to treat critical illness polyneuropathy and myopathy, and to facilitate and improve the long-term recovery and functional independence of patients and shorten the duration of mechanical ventilation and hospitalization. So just by reading the statement, rehabilitation has two effects, short-term, long-term. Short-term is it decreases the ventilator duration and hospital length of stay, as well as improves the long-term recovery and functional independence of these patients. Just one slide to talk about what WHO has done for rehab. This is way back in 2017, even before COVID was known to anyone. So in February 2017, in WHO headquarters, they had a meeting called Rehabilitation 2030, a call for action. So the objective of this meeting was to draw attention to increasing needs for rehabilitation, and also it was a call for a coordinated and global action towards strengthening the rehab system in various health systems. So this is another picture from their slide where it says, integrating the rehab into the health system. So it starts right up at the Ministry of Health, and it goes to the community level, the hospital level, and even after hospital discharge, how rehab can help these patients worldwide. So how do you screen for these patients? How do you make use of the opportunities that you have to take care of critically ill COVID patients? So in order to establish the screening opportunities, it has to be a multidisciplinary team approach. The general practitioner or the primary physician taking care of these patients, in conjunction with the rehab team, the rehab physician, the physical therapist, psychologist, as well as the critical care physician. All of us working together can help improve the quality of life of these patients. So these are my resources, mainly from CDC website and WHO. And that's the end of my talk today, just focusing on rehab for COVID-19. Thank you very much for listening.
Mom, you can stop sharing your screen.
Sure.
Yeah.
I'm happy to take any questions related to my talk today.
Thank you, Dr. Navita Ramesh. I think there's a network issue. So It's fine. Thank you, Dr. Navita Ramesh, for giving us a comprehensive overview of ICU management for COVID-19 patients. And we would wait for some questions from the panel. And also, I would just want to run through your discussion for the last half an hour, 40 minutes. So just gave an introduction on the COVID-19 scenario and what is COVID-19 and how is the infection spreading, and then the global scenario. Subsequently, we run through the symptoms which is commonly experienced through COVID-19 patients. So I'll just quickly run through a question which came in. So the question asked by Anya Leong: how long early to start rehab in ICU during ventilation stage?
So my answer to that is the sooner the better. We usually start physical therapy on day one of ICU admission, physical therapy and occupational therapy consults on all our patients. Even if the patient's intubated, we could do passive range of motion. There's mobility bikes that can be used for patients who cannot actively participate. But I think the earlier the better for rehab in the ICU patients.
And another question by the same person: was there any research done related to sensory issues?
Not that I was that I know of. It's mostly related to cerebrovascular accidents or strokes. That's coming more and more now, given the early recognition of the hypercoagulable state. But I've not seen much on sensory issues so far.
All right. Another quick question which I was thinking about. So most of these patients, we had discussed extensively about the neurological complications which happens in post-COVID related syndrome or post-ICU syndrome. And especially speaking about critical illness, neuropathy, polyneuropathy, or even myopathy. So in these patients who are intubated, what are the diagnostic challenges to identify these patients who are having or undergoing process of multiple neuropathies or polyneuropathies? Do you have any experience in that?
I think it's a little bit challenging in this situation because the virus itself, as I mentioned, can cause myositis or muscle injury. So solely going on creatine kinase may not be the answer for that as a lab value. So I think assessing these patients on a daily basis and looking at trends, is the CK increasing or decreasing, what's happening with the LDH, also looking at the patient itself, what medications are you giving them? Are you heavily sedating them or paralyzing them? So there is no clear cutoff to say, once we hit this lab value, it means the patient's developing critical illness, myopathy or polyneuropathy.
Another question just over it, I would say, like, do you do any nerve conduction studies just to screen for these patients?
As of now, no. But I think eventually when the actual volume of cases in the ICU decreases and there's more chance to do more studies, that would probably come up, but at this point, no.
All right, actually, I have a quick question as well. I know you had mentioned a lot about these physical issues that patients are experiencing. I would also imagine that these patients have, because they are intubated for a prolonged period of time, they would also experience, to some extent, issues with their swallow or their speech. So are they involved early on, the speech-language pathologist, in this ICU rehabilitation, and any research or anecdotal evidence on how that can improve the outcome of the patients?
Sure, I think it's interesting you brought up this the topic of speech therapists. So some case reports have been coming up where with patients with COVID-19, they have significant airway edema to begin with also. So even the intubation itself might be a difficult intubation. And, given the airway edema, once you extubate them, there is concern for dysphagia and also concern for difficulty, they could develop stridor and reintubation. So the patients are usually, the reason why they are not why they need that degree of prolonged mechanical ventilation is the patients are, at this point, we are waiting until we think a patient can tolerate up to 6 liters of oxygen by nasal cannula before extubating. So usually, prior to COVID-19, if a patient had CHF or a patient has COPD exacerbation, you intubate them for 2 or 3 days, and then you extubate to BiPAP, or you extubate to a high flow nasal cannula, or do a TP trial and give extra oxygen support after extubation, like a non-invasive ventilator strategy. That is, in early on with COVID-19, that was initially not recommended, because once you put non-invasive ventilation, it can cause increased aerosolization of the particles affecting the people around. And so that's why we wait till the patient is so stable that he needs only maximum of 6 liters oxygen before we actually extubate. So that's the reason why there's prolonged mechanical ventilation, and it definitely causes airway edema and increased risk of stenosis later on. So I think it's key that we have speech and swallow therapists involved as soon as the patients are extubated. The therapists here, they've all been N95 tested. And so once the patient's extubated, we do a formal speech and swallow evaluation. And some of these patients undergo FEAST study with the swallow therapist, like a video study, to see if they're able to tolerate oral diet. And I'm sure more and more evidence will come out on this, but as of right now, it's the virus itself causing airway edema, as well as the prolonged mechanical ventilation that can affect that can cause stridor or dysphagia issues.
Wonderful, thank you. I think there have been a lot more questions, Dr. Jacob.
Yeah. So there's another question. What is the therapist-patient ratio and the possibility of therapist exposure to false negative cases?
Yeah, I think that's an area of huge concern. The tests that we have now are not 100% sensitive or 100% specific. So I think at this point, if a patient's intubated and they've been, at least 2 weeks off of the mechanical, at least 2 weeks of mechanical ventilation, then extubated, I think the risk becomes a little bit lower. So the sicker the patients are, the more infectious they are. And so once you've recovered from the critical illness phase, the risk of transmission is lower. So from our ICU, we have 2 therapists working with each patient. They, along with the bedside nurse as well, because they do require significant support once they are ready to get to rehab. Our therapists still wear surgical masks while walking these patients. I don't know if it's standard of care, but that's what we've been doing.
And so in terms of involving therapists, to say respiratory therapists, when exactly do they get involved in the ICU care?
So the respiratory therapists are involved from day one. Mm-hmm. So the respiratory therapists, to help with the ventilator management, they are key personnel in patient management, especially in the ICU, because I did not go into details about this, about how do we manage the ARDS. We want to make sure that we don't hyperinflate the lungs, and we do standard of care with low tidal volume ventilation, which is about 6 to 8 ml per kilogram of ideal body weight. And we want to make sure the plateau pressures or the airway pressures in the pressure within the patient's airways are not significantly elevated, because it can cause significant trauma to the lungs. So just background about this is when we breathe in our lungs, when you're not intubated, it's negative pressure system. But when you're intubating a patient, you put them on positive pressure, causing significant strain in the lungs. And so if a respiratory therapist is not monitoring or not keenly watching the numbers on the ventilator, there's a high risk of lung collapse or pneumothorax that can happen with these patients. So we involve our therapists right away. And there are frequent checks during the day to go over the ventilator numbers and the patient characteristics, because they'll be the key in identifying patient ventilator asynchrony, and that will help us in deciding heavier sedation and paralytics. So I think it's a team effort with respiratory therapists involved.
So there's another question. What strategies have been used to avoid therapist transmission from false negative to true negative patients?
So similar to speech therapists, our respiratory therapists are also fit tested. So when they enter a COVID-19 patient's room, they do wear an N95 mask with an eye shield, or they have the capper or the full body shield that they wear. So we do take those precautions before the therapist goes inside to the patient's room.
And is there any difficulty in managing secretions in patients with ARDS, especially in COVID-19?
The patients do have secretions, and they might need suctioning, but our recommendations so far, what we've seen is they don't have very thick secretions like how you would have in a bacterial pneumonia that can cause mucus plugging or lung collapse. The secretions are usually thin, almost like frothy pulmonary edema kind of secretions. So our nurses and therapists usually do suctioning, inline suctioning routinely on patients, but for COVID-19 patients, they're not doing it as they would do for other patients. But it's okay to suction them. It's okay to use inline suctioning as long as you're wearing the protective equipment, the personal protective equipment, and also in a negative pressure room.
So there's another question which says that, like, FEES being an AGP, can you highlight on the role of ultrasound of larynx?
Could you repeat that for me? I didn't hear the first part.
FEES, the screening, FEES,
Yeah.
being an AGP, can you highlight on the role for USG on larynx, ultrasound on larynx?
Sure. I don't have much data to talk about the ultrasound of the larynx. And FEES study too. We've not done FEES so far on a positive patient so far, but that's a usual standard. So a patient, forget COVID-19. So if a patient's intubated, a patient gets extubated. The nurse does a bedside dysphagia screen. The nurse says, can you swallow? Or there's a screening questionnaire that the bedside nurse does. And if it's positive for any of those points, that will trigger a speech therapist consult. So the speech therapist then assesses the patient, and the speech therapist gives food of different consistency, and the speech therapist thinks that's good enough, then we let it be there. We give the patient the diet that the speech therapist recommends. But if the speech therapist thinks that this patient has a significant difficulty swallowing, then they order a FEES study. So it comes from the therapist themselves. So there are several steps to be taken before doing FEES. Also, like you said, it could be aerosol generating. So we're being very careful of, we're not blindly ordering FEES on every patient. It's a multi-step approach. The nurse assesses, the speech therapist assesses, then the physician, and then we decide if this test is needed or not.
And is there a role for cough assist machine in patients with ARDS?
We do not recommend cough assist device. We've not been using that.
Any specific reason you would want to mention?
I think it's more of, at this point, there are so many uncertainties with COVID-19. Is it aerosol generating? What is aerosol generating, number one? And, is droplet precautions enough? Do we need a negative pressure isolation? So there's a lot of questions that are not answered. So even chest vest therapy and any kind of chest physical therapy is done with utmost caution. And cough assist, the one main population where the cough assist has been useful is patients who have neuromuscular disease and respiratory issues secondary to neuromuscular disease. We use cough assist, but otherwise just for COVID-19 respiratory failure, cough assist is not recommended.
So another question, we were discussing about neurological complications related to COVID-19. So what is the role of EEG in terms of identifying non-convulsive status epilepticus if in case a patient is going through that? Or have you ever tried in administrating an EEG for a patient who is comatose?
So this goes back to, again, regardless of if this patient has COVID-19 or not, if a patient's been intubated, you've taken off all the sedate, you think the patient's ready to extubate, right? You hold all the sedative medications, and then you assess the patient to see if this patient's waking up and following commands. And if the patient is not showing significant improvement, then you do EEG to look for non-convulsive status. I think the same thing has to be used in this COVID population as well. There's no specific literature with EEG use in COVID. So it just goes with when you do spontaneous awakening, spontaneous breathing trial, and the patient's not improving as you would expect them to, then you start thinking about non-convulsive status.
So we're still waiting for some more questions.
Sure. I think, if we were to have this talk next month, we'll have different set of evidence. This is as we stand right now, and as more and more cases come out, more literature comes out, we'll probably have answers, like solid answers for all the questions that were asked.
I agree.
So would you say like the post ICU syndrome, post ICU syndrome could happen after any infection, leave alone COVID-19. So how different is it in terms of managing COVID-19 and compared to the other patients?
So I think post ICU syndrome could be any reason the patient's in the ICU. Like it's not just an infection. So if a patient is in the ICU for, let's say, he's a severe COPD or has a COPD exacerbation, admitted to the ICU, no infection, no, like a bacterial infection as such, but they've been in the ICU and given their lung disease, they've been intubated for a really long time. That also can cause a post-ICU syndrome. So that's not specific to any infectious etiology. It could be non-infectious in origin as well. I think the focus right now on COVID-19 is mostly because of the duration of mechanical ventilation. So as I said, if evidence comes out later that it's safe to extubate them early, or it's safe to put them on BiPAP, or it's safe to put them on high flow, then maybe they would not need this duration of mechanical ventilation. So I think the longer the duration of mechanical ventilation, the higher chance of developing post-ICU syndrome. So if we focus on getting them off the vent earlier, then maybe the post-ICU syndrome won't be as severe. But until we have more evidence of safe extubation strategies, safe early extubation strategies, I think the long mechanical ventilation is going to be an issue.
So there's another question. Can you highlight on the tracheostomy care and management for COVID positive patients?
So, tracheostomy is usually, regardless, again, going back to prior to COVID-19, if a patient's intubated for about 2 weeks, like 10 to 14 days, we start talking about tracheostomy, usually done by ENT or trauma surgery. And that's where we were before this. At this point, we've had case reports where patients have been intubated for as long as 3 weeks, extubated, not needing a trach. But if you were to do a trach, it has to be, again, under high precautions of negative pressure room with airway protective equipment, full PPE. So that's the main difference here, because once you enter the trachea, it's aerosolizing again. But at that point, if you're thinking about the trach, it's the hope that the patient's not as infectious. Like they've been on the vent for so long, maybe they've crossed the hump, and now it's time to work on rehab for them. So they're not as infectious is the thought process. So, but you still have to do the negative pressure isolation, N95, or full PAPR or CAPR gown. So you still have to take all those precautions.
That's a very good question, a very good answer.
So we have another question here. So what is the role of occupational therapist in COVID-19 patients?
So the occupational therapist, it's, I hate to say this, but it's going back to pre-COVID-19, right? Even before COVID hit us. COVID is a new infection, but even before that hit us, occupational therapists were very closely involved in patient care in the ICU. So they usually go hand in hand with physical therapy. So you want to get this patient back to their functional status, what they were doing prior to coming to the ICU, right? So that's the main goal here. So, walking up and down the stairs, like transferring themselves independently from the bed. So it's usually we work hand in hand. It's whether you have COVID-19 or did not have COVID-19, I think they are one of the key personnel in ICU rehab. The goal is to get this patient back to normal pre-ICU stage or as close to the pre-ICU state as possible.
All right, I think that's pretty much all the questions.
Yeah.
Dr. Jacob?
Yes, I think we have got all the questions given to Dr. Navita here.
Thank you. Yeah, as I said, it's more on, I'm sure within the next couple of months, we'll have more evidence, and things it's a fluid state, so things will change with this disease.
Yeah, that's a very important disclaimer.
Yeah.
All right. I think we could finish off with the presentation, and thank you, Dr. Navita Ramesh, for giving us a comprehensive overview of COVID-19 management and ICU care. And more than the ICU care, you had touched more on the rehab perspective. And I'm sure everyone will benefit from this discussion. And I would also invite the participants to participate in the upcoming webinar series, which should happen tomorrow between 5 to 6.
Thank you very much for having me here.
Thank you.
Thank you, Dr. Ramesh.
Thank you.
So for further queries or any question, you can please contact or WhatsApp or to email to the following number and email ID. And for tomorrow, we have overview of impairments noted in post-ICU syndrome, benefits of early intervention and role of a physiatrist by Dr. Michael S. Cullen. So you can log in by 5 p.m. tomorrow.